Hello everyone, and welcome to HealthSpace2030, here at Messer, Israel's Center for Medical Simulation at Sheba City of Health. Sheba is the largest medical center in Israel and a leading global medical provider, recently ranked in the top 10 best hospitals in the world. I'm Avner Halperin, a digital health entrepreneur, co-founder of EarlySense, and chairman of the board of iControl. I lead here the Patient Room of the Future initiative. Over the last year, we've been working on building the concept of the Patient Room of the Future. We call it HealthSpace2030. The purpose of the room is to allow entrepreneurs and clinical teams to dream, develop, test next-generation technologies together. We built an environment that opens Sheba's door to new initiatives, test them in a realistic sandbox, and then share them with the world. 6 months ago, we presented our vision for the future of COVID-19 technologies and got phenomenal feedback from thousands of participants. When we asked many of the participants, including many of you, what would you want us to integrate next, the overwhelming majority said telehealth technologies. So we put together this room that you see here that simulates a home of a patient. We have two versions, one for older patients and one for younger patients. And in this room, we will do a series of HealthSpace2030 events on telehealth technologies, with the first one, this one focused on the hospital-at-home solutions. We're leveraging three key strengths here of Sheba Medical Center. First, the Sheba Arc platform that partners with companies, small and large, and leading medical centers all over the world to promote innovation. Second is Sheba Beyond, Israel's first virtual hospital with a vision to provide the most advanced medical services to anyone, anywhere, anytime. And third, Messer, Israel's Center for Medical Simulation, that is one of the most advanced in the world in its ability to combine technology, cutting-edge simulators, and human actors for the most realistic clinical experience and training opportunity. On our agenda today is a look at some of the most exciting telehealth technologies and how they impact the hospital at home. We will see them in a realistic simulation prepared here by the Messer team. Shortly, we will meet Mr. Solomon Goodman, a fictional patient, and see his journey from admission to discharge, all at home, surrounded by the latest technologies. We will see several systems in actions, some that are already in use here in the hospital, and some that are in evaluation and development as part of our 2030 vision. We will see the story of Mr. Goodman in 6 quick videos representing 6 phases of care of his admission. And after each video, we will have our expert panel here review the technologies and answer questions. At the end, we will also be open to your questions. So please send your questions through the chat box, and feel free to send any requests for more information and any follow-up requests, and our team will respond to them, some in real time and some after the webinar. Note that this webinar is being recorded, and the recording will be available online. So let's jump right in and start first by seeing the medical background of our fictional patient, Mr. Goodman, this hospitalization, and then we will turn to our experts. So please, let's start with the first video section.
Solomon Goodman, 68 years old, was transferred for continued hospitalization to the internal medicine department after he was defined as recovering from COVID-19. Chronic illnesses, obesity, diabetes mellitus, heart failure stage 2, and chronic obstructive pulmonary disease. Mr. Goodman caught COVID-19 and he was hospitalized for 10 days. After he became PCR negative, he was transferred to the internal medicine department for continued treatment due to a clinical impression of right leg cellulitis. During his hospital stay, deep vein thrombosis was ruled out, and he was started on intravenous antibiotics 3 times daily. Mr. Goodman has a supportive family. His student son, Adam, lives with him and can help. Therefore, he has been recommended to continue his treatment at home under the supervision and care of the Sheba Beyond hospital staff. He was hospitalized at home in the past for various medical reasons, and some of the tracking technologies are already installed in his apartment. He was sent home with an established peripheral venous access, the area of infection on his leg marked in order to track inflammation progression or regression. The son received instructions in the hospital on how to administer the medicine intravenously, and 3 doses of antibiotics are supplied to him on a daily basis.
We're very fortunate to have 3 outstanding experts. In the spirit of the recent Abraham Peace Accords, we are bringing inputs from Israel, United States, and the United Arab Emirates. Our first expert, Dr. Galia Barkai, is General Director of the brand new Sheba Beyond Virtual Hospital of Sheba, just landed hours ago from the United Arab Emirates, where you announced a partnership of Sheba Beyond with Al Tadawi Healthcare Group to provide the first of its kind telehealth partnership between Israel and an Arab hospital. Dr. Barkai, what is Sheba Beyond Virtual Hospital, and what were you doing in the United Arab Emirates?
Yeah, so all this is very exciting. I just came back now from the airport. So Sheba Beyond is actually the first virtual hospital. We're really aiming to change altogether, to redesign healthcare by allowing people everywhere, around all over Israel and around the world, to receive the treatment of Sheba's expert that brought us to be on the 10th best hospitals list, with advanced technologies, and together to create new models of treatment from people far away.
Right. And we're also very fortunate to have on our panel Dr. David Levine, who is a physician and researcher at the Division of General Internal Medicine at Brigham and Women's Hospital and director of Brigham's well-known home hospital program. Dr. Levine, we saw in this intro video the patient's medical background. From your experience at the Brigham, which are the key points in patient selection critical to the program's success? And thank you again for joining us. I can't hear him.
Thanks, Avner, so much for having me. It's really a pleasure and a privilege to be with the panel today, and excited to kind of look at HealthSpace 2030 with everyone. You know, a lot of important points in that video and a lot of nitty-gritty clinical details would have to be determined in order to look at kind of the severity of the patient's COPD, the severity of the patient's cellulitis, and we'd actually probably want to think about some clinical risk scores to ensure that the patient is appropriate for home hospital care. Something makes me believe that will be the case.
Great. Okay, so I think we are ready to see our first clinical video of how our patient is being treated in the hospital at home. So go ahead.
It's good to be home.
Okay, Dad, so let's see what we have here. You remember they said there's a tablet in this box that will explain everything about your home hospitalization. Let's look at it together.
Just a second. Help me sit a little higher. I'll eat something and then we'll look at it together. It's so nice to be home and that you're here with me.
I'll get you something. Let's look at it.
Hi, my name is Michelle, and I'm a nurse at Sheba Beyond. We take care of our patients who are hospitalized at home. I hope you've made it home and that you've settled in comfortably. I would like to explain the daily schedule of your home hospitalization and the way you will keep in touch with the medical staff. Additionally, you can receive explanations about the various support systems we've supplied you with to track your health. Take the time to read and listen to the explanations, and afterwards we can talk and make sure everything is clear. It's important to us that you feel that you're in good hands. Now you will see on the screen several buttons with the different modalities. Please press on the icons to navigate between them.
This is the oxytone bracelet.
Okay. Okay.
This is the dock. You need to connect this to your phone.
All right. Like that, huh?
Yep. Tidal Care. This helps monitor your heartbeat and other things.
Okay.
Okay. So we saw the beginning of the journey of our patient, Mr. Solomon Goodman. And now our third panelist, Dr. Gadi Segal, is the head of the Internal Medicine Department and head of the Education Authority at Sheba Medical Center.
Hi.
An expert on robotics and other advanced methodologies for remote patient care. Hi, Dr. Segal.
Hi, Avner. Good evening.
Good evening. Dr. Segal, we saw the oxytone watch being used. What is the value of getting continuous temperature, oxygenation, and heart rate continuously from a watch like oxytone? Why can't we just use a standard finger oximeter at home?
Well, paradoxically, this technology, when displayed as a telehealth technology, is the technology that I would like to have in my ward within the hospital. So this is the realization of my dreams regarding continuous monitoring of patients. The continuous monitoring of patients enables us to control the patients in two terms. One is to paradoxically be there when things happen. So right now, why am I saying paradoxically? Because I'm treating the patient remotely, but actually I'm there each and every minute and second when something might go wrong. Second, only continuous monitoring enables me to accumulate big data on these patients. And the big data enables us to execute prediction models.
Yeah, we'll touch on that, I think, in a minute, yes. Thank you very much. And what we also saw in the video is that effective hospital at home care is all about excellent communication. And we see the Kaltura solution that does a personalized video and generates interaction data on how the patient is engaged and how he responds to questions and whether he understands the video. So Dr. Barkai, how do you see the importance of patient engagement for home hospitalization and the value of video solutions for that engagement?
So when you send a patient at home and you want him to be hospitalized at home, it's a key factor that he's engaged in the treatment. He's actually part of the treatment, not only the patient, but also the caregiver. And if you don't have a patient that's engaged and a caregiver that's engaged and trust the team, it would not work. So I think video is really helpful in that means, because using the video, you can really connect effectively with the patient as you're in the same place.
Absolutely. And Dr. Levine, your home hospital initiative is one of the pioneering projects in the world. What did you do to enhance patient engagement in your home hospital's project?
Abner, you're very kind. There's a lot of really amazing home hospital programs throughout the world going on right now. You know, patient engagement for us is paramount. And really, we do it in a very often high-touch manner. We're working with patients who are very old and often struggle with tactile interfaces, right? Tablets, phones, things of that sort. And so a lot of our patient engagement is very much high-touch in the home with the patient, working with them and their family. And, you know, I think we're moving in the right direction when it comes to the usability of tactile interfaces. But I think we're going to push even beyond that in the future, where we're using, you know, holographic systems, which have been pioneered in Australia, as well as, you know, AR and VR systems to engage with our patients in an even deeper level, potentially in the future.
That's great. Thank you. And I think we're ready to see the next stage of our patient journey. So go ahead, please.
Alexa, what were the numbers from my mattress last night?
I see that early sense detected average resting respiratory rate of 22 respirations per minute and heart rate of 88 beats per minute.
Hello?
Good morning, Solomon. This is Eleanor. I'm calling on behalf of Sheba Hospital to check in on you and see how you are doing. I'm going to ask you a few questions, and the hospital staff will be in touch with you later on. How are you feeling this morning?
I'm still very weak, but it's good to be home and sleeping in my own bed, and it's good that my son is with me.
I'm happy to hear that. How did you sleep last night?
My leg hurt a little, so it was hard for me to move in bed. I had to sleep sitting up because I had a little trouble breathing. And I got up 5 times during the night to use the bathroom.
I'm sorry to hear that. Have you taken your temperature this morning?
Yes, I saw from my bracelet that my temperature was 37.3 degrees. That's lower than it was yesterday.
I'm glad to hear that. How would you describe your mood these days? Do you feel like you have enough support around you?
I have my son here with me, so I'm managing. Thank you.
I understand. Is there anything else you want to tell me today?
No, thank you for your call.
Thank you, Solomon, for your cooperation today. Have a wonderful rest of the day. Feel better. Goodbye.
Good morning, Dad.
Hi.
How are you feeling?
Still weak. I just finished talking to Eleanor, and I told her how I was feeling. I'm going to go back to bed, I think.
Yeah.
Doctor, I'm looking at the data we received from Eleanor's conversation with Mr. Goodman, as well as what the EchoCare system in the room picked up, and it looks to me as if his breathing is getting worse. I'm going to collect more data from the oxytone and DocDoc systems, and I'll talk to the patient and ask him to do a spirometry test through DocDoc so that you can have all the data for the doctor's round.
Great. Thank you.
So what we saw here is the importance of collecting continuous information about patients' condition at home and how crucial that is. We see several technologies in that last video. Early sense with a sensor under the mattress, and voice communication through Alexa. EchoCare that detects patient location, movement, and falls and breathing with a radar sensor that's placed here actually on the roof. And MindU's My Eleanor voice bot that calls the patients and talks to them at home and both analyzes the text they answer as well as their voice patterns to check how they're doing and get them more engaged. Dr. Segal, you've been working with Early Sense on patient early warning scores for deterioration such as COVID-19. And you mentioned earlier the importance of big data. So what is the potential impact of such AI-based solutions and what have you used them for?
We've been using the Early Sense score system and we've helped developing them. And so we are using basic physiologic parameters, heart rate and respiratory rate, and assimilating them into the model, also with the age of the patient. And based on the big data that was accumulated with the COVID-19 patients, we can now have a very early warning sign, which is much earlier than the simple monitors would give us. And therefore, we are dealing with 3 points in time. One point is the point that we would address the patient as if he was hospitalized and something happens phenotypically and we go there. This is one point. The second point is a bit earlier. This is the point in which we could find it if we would look at the monitor continuously, that we are not doing from the ward, but we are doing from home. Mm-hmm. The third most important point is much earlier in time, the point in which the prediction model can announce a future deterioration, which now ranges by hours. So knowing that the COVID patient is going to deteriorate in hours will enable us to act and even to prevent mechanical ventilation and to know how to leverage all other life support systems that we use.
And such solutions developed for COVID, obviously we will see in the future for other deteriorations as well in the home, I expect.
Yes, because the COVID takes it to extreme.
Of course.
But heart failure and chronic respiratory diseases have very similar patterns of deterioration.
That's great. And Dr. Levine, we saw in the video voice being used both to engage with different sensors in the home as well as to actually analyze the voice parameters and for detecting how a patient is doing. Where do you see the value of these voice solutions in the home, and do you see them making a major impact in the future?
I absolutely do, Avner. I think, as my prior comment suggested, a lot of our patients really struggle to use tactile interfaces, more advanced, tablet-based interfaces, and they're much more used to talking. And so I think this sort of an interface, while always has the ability to grow in terms of its humanness, I think has a lot of potential to help with the way that we monitor our patients and check in on them and get what we call patient-reported outcome measures in a more automated fashion. And then, as we all know, it's a really burgeoning field looking at an analysis of audio, right? It may be that analyzing somebody's audio in the home is actually more predictive of deterioration than their heart rate and respiratory rate.
Yeah.
And that we haven't cracked that code yet, but certainly is a really interesting field.
And voice engagement for elderly people is obviously especially important, as you suggest.
Huge, huge.
And Dr. Bakai, we saw the Echo Care as a radar solution that collects information of where a patient is at home, if he has fallen down, there's breathing information. And how do you see that? What the value of that in a home hospital scenario?
So it could be really important to us to know how the patient is doing in the space. For example, how much he moves. It might say that he is better unless he goes more to the toilet because he's more loaded. So that's one thing. And also, if you can detect more falls, we can see that something may go wrong. Maybe it's not the right patient to be at home. He needs to go to the hospital or need to undergo further evaluation. So it can give us a lot of very important information.
Okay. Thank you very much. And I think it's time to see the next stage of our patient's journey, please.
Good morning, Mr. Goodman.
Good morning.
I'm Michelle. I'm the nurse who's going to take care of you from Sheba Beyond. You probably saw me in the video. Later, you'll meet Dr. Eve, who's also in charge of your care. We will talk with you every morning, and just like in the hospital, we will track the information we're getting from Eleanor, as well as all the information we're getting from all other monitoring devices. But first, please tell me, how do you feel?
I'm tired, but I'm happy to be at home. I hope that you really can see from there how I'm doing. I told Eleanor that I had a difficult night.
Yes, Eleanor told us. How about we go over your vitals together? I can see on your oxytone bracelet that your temperature is 37.3 and that your oxygen saturation is 94%. In a minute, we'll do some tests to check what's going on with the devices you have at home. I'm also going to ask you to weigh yourself. I understand that you're still weak.
Yeah, that's right.
That makes complete sense. I also see that your glucose levels are higher than usual. I'm going to consult Dr. Eve about that. I'm going to ask you to straighten your arm for me so that I can see the vein access.
Just a minute. How about that? Can you see that?
Yes, the vein access looks completely fine. I'm also going to ask you to show me your right leg so that I can see how the area of the infection looks. There we go.
Can you see that?
Yes, your leg is also improving and the redness is in regression. I also see through the DocDoc IBM system that's next to your bed that you were restless last night and that you coughed a little. Is that correct?
Yeah, that's right.
The good news is your lung restriction hasn't worsened. Don't forget to weigh yourself and enter it into the data system.
I will, okay.
Your weight has gone up a bit in addition to the measurements associated with your breathing. I think you may have accumulated some extra fluid. I'm going to talk to Dr. Eve about that. I'm worried about Mr. Goodman, our patient who is at home with cellulitis. From what he told Eleanor and from the data that we've collected, I think he's accumulating fluids. Other than that, he's urinating frequently and his glucose starting to rise.
Okay, we should consider maybe raising his diuretics dosage and also change from metformin to insulin. So let's contact him for a morning visit.
Okay, great.
So we saw the nurse visit with the patient and the discussion then with the physician based on the data that was collected. But before talking about that, we did get a question through the chat about patients who are not lucky enough to have a son or a daughter living with them to help support in the use of all these technologies. So Dr. Bakai, is that a requirement that we have a patient member who is young and able to activate the devices?
So it really depends on the patient himself. It depends on the degree of severity, his age, his ability to operate the systems. But yes, many times we will choose the patients who have younger, either children or someone to take care of them at home that can help in times of trouble and also to help with the technology. So yes, most of the times we'll do it when we have a family member that can help.
And so thank you, and thank you for sending that question over the chat box. I understand that some people are not pressing the send or the red button in order to send the question, so please make sure you do that so the questions actually make it all the way to us. Dr. Levine, we see a lot of monitoring solutions being in use, and one of the key challenges with home sensors is the challenge of patient compliance. So how do you see these technologies, are they answering that need, and how do you see the overall issue of patient compliance at home?
It's a great question. And, I think it gets to the point that we are still really at the tip of the iceberg when it comes to monitoring patients in their home, meaning we have a lot to learn. And so we probably have a lot to learn in the hospital too, and haven't invested sufficiently in it, but we particularly have a lot to learn in the home. Right, like even as a clinician watching that video, I'm sure other clinicians noticed that the patient was much shorter breath, right? But that wasn't actually necessarily a focus of all those different monitors. And so the question is, are we focusing on the right thing? And I think there's a lot of work to be done with machine learning in this area and combining a lot of different sensors, as well as trying to figure out what sort of kind of touchless sensors can we be manipulating in the home so that we don't have issues of patient adherence and that patients simply need to passively do what they do best, which is relax and heal, and that our sensors can then work to improve kind of our eyes in the home. That said, many of our patients can't use a lot of the sensors that we would like to have there. And so we do really favor what I like to call passive sensing, whether that is a wearable that can stay on or it's a system in the home that simply sits there. Those, I think, are some of the best options that we have because of things like low health literacy and patient adherence.
I would like to relate to that and say that we have to put in front of the patients our best clinicians, because still our clinical experience and clinical knowledge is the most important thing. And we as clinicians, Dr. Segal and me, we see the technology as something that helps us, but it does not come instead of the clinicians themselves. So it's really, really important that in every of these programs, the most expert clinicians will be.
Yeah, and turning to you, exactly according to those points, we saw one type of sensor that was sent over, and that's a TytoCare that I think, Dr. Segal, you have experience with. You actually used it also in the home and the hospital environment, I believe. Can we trust remote tests administered for patients on themselves, like with the TytoCare device, for example?
Currently, we believe that medicine should be personalized. Now, telemedicine is no different. You should personalize the tools that you are using. And if the patient is having difficulties using the Tyto, so the Tyto won't fit. And as David said, as the monitor is more passive, then it is more easier. I used the Tyto with COVID patients. It's been a huge help because it enables true physical examination in terms of restriction. So this gave us a huge step forward, and still it necessitates either being used by the patient himself or that some staff member is by the patient and helping him applying the Tyto to his cardiac auscultation or the lung auscultation. If you want to hear the lungs from the back, you must have someone to help you, but it's been a huge step forward.
Great, and I think we'll see some more of that in the next video segment, so please let's run that one as well.
Hi, Mr. Goodman. I'm Dr. Eve from Sheba Beyond. I understand that you had difficulties breathing. I'd like to hear from you. How are you feeling?
Dad is really weak. He says it's hard for him to breathe. His leg actually looks like it's getting better.
Okay, well, Mr. Goodman, you're in very good hands at home. What I'd like to do is to listen to your heart and your lungs via the Tyto device. So I will need your help, and Adam can help you as well. If you could please open the Tyto application. Good. Now attach that main part of the device that serves as a stethoscope.
Like this?
Yes, exactly. Very good. Now, if you could place that on that first point, according to the diagram on the screen. Mr. Goodman, in light of what you told us about going to the bathroom many times during the night, we will monitor the data we're getting from scanning your urine via the OutSense system.
Okay, that sounds good.
Alexa, please call Nurse Michelle.
Calling extension 20.
Michelle speaking.
Hi, this is Adam, Mr. Goodman's son. I was wondering if you've seen anything on the OutSense system.
Hey, Adam. Let me check. Good news. I see there's no alert for an infection. I'll let Dr. Eve know.
Thank you.
So we saw the remote physician visit, and Dr. Barkai, in the Sheba Beyond model, you're one of the earliest in the world to have the physicians do all the rounding remotely. Can we truly rely just on remote technologies for acute care patients, or do we have to send doctors to the patients' homes?
So as I said before, it has to be very good clinicians that can look at the patients, analyze the data very well, and most of the time we can manage without having to go to the home of the patient. I believe that through video you can communicate effectively with the patients, see them, see their environment, and learn a lot from it. But sometimes, yes, it's not enough, and we do have to send someone at home or either bring the patient back to the hospital. So there's no one solution that fits all clinical cases and everyone.
And thank you. And I think, Dr. Levine, you have a slightly different approach in terms of physician visits to the patients at home, right?
So I think, we probably have more similarities than differences. We definitely have a focus on our physicians and nurses and paramedics being in the home very consistently. For a lot of reasons, again, health literacy reasons, embarrassingly as well. Despite Boston being the med tech capital of the United States, we can't get a 4G or even a 3G signal often in our homes and in patients. And so it's not possible to do high quality video like we're seeing in this vignette here. In fact, sometimes we can hardly get a phone call to go through. And so that really does, that really makes it hard for a physician to treat the things that she or he wants to treat. That said, we have recently finished a randomized controlled trial of physician care, both comparing remote physician care versus in-home physician care. Look forward to kind of publishing those results and sharing them with everybody in the coming months. Can you share
some of the data?
Any hints you can give us?
So I can say, it all depends on the model, right? And again, our model is also still based on a physician home visit on start, followed by remote physician visits, and lots of caveats behind how often a physician needs to switch over to an in-home visit. So I think, important, but we are seeing very positive results for remote physician care. Again, with a very large, important caveat that physicians need the ability and the logistics to be able to see their patients in the home still moving forward.
That's great. Thank you. And thanks for that sneak peek. And the other interesting technology we saw in that last video was OutSense, which is a kind of a leader in the important trend of medical lab in the cloud, where we collect data at home and upload that information to the cloud. They collect information about human waste automatically, so also on the point of patient compliance, it's important, and can help detect blood and stool, urinary tract infection, dehydration, diarrhea, constipation, etc. Dr. Segal, can you tell us about the benefits of getting such a cloud lab results from patients at home automatically, and what kind of efficiencies or improvement in care do you think that provides?
Accumulating data regarding various biochemical, both physiological and biochemical parameters enables us to build up the big picture of the patient. Now, when we want to control patients from remote, this serves partially as a substitute for our being near the patient. As David said before, we are now getting the impression that there's also a place for a hybrid model in which we keep the patient hospitalized in hospital for a day or two, and then we do the rest of the hospitalization remotely. And then you would like to do changes from your preliminary decisions. These changes are best supported when you have a thick belt of biochemical data. And as always, the physician has to decide what data is redundant and which data is important. But having this option to decide is very important to us.
Getting automatically biochemical data from a patient at home, I think, is a major breakthrough.
Is a major breakthrough, and I see it as a marker, because I have no doubt that these technologies will proceed and progress. Absolutely. And we will have more and more diagnostics and models of prediction-based diagnostics on these data.
Yeah. And Dr. Levine, you wanted to comment on that?
Yeah, I wanted to agree, and also add that I think it really raises the importance of ensuring that many of the startups and labs that are in this space are held to a really high level of evidence, right? We don't want to put something in a patient's home or even in a hospital that isn't going to be giving us accurate data. And so as we see this explosion, and literally it's an explosion of new monitoring devices happening right now for the home, for the hospital, for elsewhere, I think we as physicians and scientists want to be very cognizant that folks are presenting to us a very high level of evidence that these devices work, that they're not going to be giving us false positives, false negatives, and that it's being peer reviewed in a very robust way.
That's critically important. I think we all agree on that.
Yes.
Mm-hmm. And I think we are ready for the next phase of our patient's story. Please.
Look, we're deliberating. The infection on your leg is getting better. I see the picture of your leg here on the screen, and I'm also glad that there's no sign of infection in the urine. But according to your complaints, Mr. Goodman, and the data that we've collected, it sounds like there's some body and lungs extra fluids. Now, in order to get rid of these fluids, you have the option of coming back to the hospital, or you can try staying at home. We'll increase the dosage on your diuretics, and we'll track the results. What do you say? It's important that we decide together.
Oh, what do you think, Dad?
I'd really like to try to stay at home. If necessary, we can go back to the hospital tomorrow or this evening.
Okay, I'm with you guys. So if you're staying at home, we'll take the following steps. First, we'll increase the dosage on the furosemide. Instead of 2 pills a day, you will now take 4. Adam, please notice, each pill is 40 milligrams. We're moving to a dosage of 80 milligrams twice a day. Secondly, we'll improve the treatment of the diabetes. We should stop using metformin at this point. We will send a drone over to you through the Highlander system, and the drone will deliver an insulin pen like you've had in the past. You can also find additional instructions on how to use the pen if you follow the instructions link on the Cultura screen. Also, the drone will take back a urine sample from you for culture, and you can see instructions for this as well.
Give us a call when the drone arrives, and we'll explain more about administering the insulin and make sure everything is clear.
Thank you. We'll do everything it takes to stay at home. It's really important to Dad after the long hospital stay. Dad, I got an alert that the drone is coming, so I'm going out to get the medicine and put your urine sample on it.
Okay, great.
Okay, so what we saw a few things in this video. One interesting one, and the first for us, I think, here at Sheba is the use of drones. Dr. Barkai, where do you see the use of drones expanding and kind of expanding the reach of Sheba Beyond?
So it really is expanding the reach of Sheba Beyond. It will, the use of drones will allow us to take better care of the patients and to have them stay in their houses in the convenience of their home without having to leave when they need to do tests, and we can send them things and receive things from them. We can send them medications, tubes for testing, and they can send us as well all kinds of specimens that we need. So it will, if we use the drones and for larger distances, longer distances, we can take care better of many patients who are far away from us, and it's definitely something that will be a game changer for us.
And Dr. Levine, in the U.S., obviously distances are larger, and I assume you have to cover bigger mileage. Are you seeing drones as part of your offering in home hospital?
So it's a great question, Avner. I have been working on drones for a few years now. Suffice it to say, the regulatory environment is quite behind us right now. And while there are some really quick movements happening, it's not clear that that will be approved right now beyond line of sight in the US. Although, again, we see many pharmaceutical companies and pharmacies actually partnering to do drone delivery and things like that. I think it's only a matter of time before it does come, but it's certainly not there yet. And it certainly would be very important for home hospital work. You know, we have an entire line of home hospital work based on rural home hospital care. And again, drones there would also be extremely important, as would driverless cars be extremely important to facilitating logistics. But I think, again, that's part of why the title is 2030, and we're still stuck in 2020 right now.
We're getting close to 2021, but yes. And you mentioned regulatory hurdles. Another question I saw that also come up in our chat box, and always an issue with putting so many sensors in the home, including now in the bathroom, is the issue of privacy. How do you deal with the challenge of privacy with so many home sensors? Do you have a solution for that?
Yeah, it's a great question, and it's a big concern, right? We don't want too much of a big brother when you're at home, and really one of the beauties, I think, is that we don't want to turn your home into a hospital. We want it to remain your home, and so doing that requires a very fine line and really non-invasive, non-intrusive sensors and tools. And so that's like, for example, simple things like in our program, we use an ambulatory infusion pump. It's a fanny pack, essentially, not a pole pump like you saw in the video for our patient right here. And then similarly, you know, we've had patients get completely confused that we say, you know, this wearable patch that you have on, that's gonna help keep an eye on you. And patients say, keep an eye on me? You mean there's a camera on that patch? And we say, no, don't worry. It's not a camera. It's just helping monitor you. And so patients are very, very concerned about that. And so I think we do need technologies that really maintain people's privacy, help them feel like they're still in the home, allow them to turn things off if they want to turn things off, right? And really try to find the right medium. And that's going to take more focus groups and more, you know, trial and error as we adapt new sensors.
And we also saw a lot of solutions here intended to make a live connection with the patient and alleviate a key issue of patient loneliness. So we see many cases. Mind you, with a bot caller, doctors and doc that enable real-life communication back and forth. Dr. Segal, how do you see the challenge of staying connected with the patient and overcoming the issues of loneliness of the patient at home?
I think this is one of the biggest challenges because the technology has to bridge the human-to-human connection. And as Dr. Barkai said, we are not sending home patients that don't have a sufficient family support and sufficient nursing resources. And the connection with the physician will stay as a treating physician. It cannot replace the backing of the family. It does not replace it in hospital. So currently we are promoting family presence and family support and family within the hospital. And at home it will be even more important. And I think that even as we progress with technologies, patients that need hospital for their social problems will still need it. The hospital doesn't vanish. And as I said earlier, personalization is the key, both in medical terms and social terms and personality terms.
Absolutely, thank you. And we're getting a question on the chat about doing imaging at home. You know, CT, X-ray, ultrasound. Dr. Bakari, do you see that on the roadmap coming anytime soon?
We do see that on the roadmap. We have started some pilots with women's health technologies that do monitoring of the fetus and ultrasound self-performed. So it's definitely one of the things that we're going to do in the future, in the near future.
Dr. Levine, you have any of these technologies already in use at home?
Yep. So right now in our home hospital program, we do use point-of-care ultrasound, as well as the ability to bring in X-ray to the home. And so those are all really great options and modalities. Honestly, point-of-care ultrasound helps us with line placement, with assessment of the lungs, with assessment of the bladder and the liver, the gallbladder, and many other areas. So it has been a very useful piece. We also have the ability to, by kind of remote video, bring in an expert radiologist to help us because, you know, we're generalists, we aren't radiologists, and so the ability to bring folks in by telemedicine is also, the potential is really big there.
And that's, I think, a very important point, the ability to connect specialists, both in the hospital and home, as well as the regular hospital, to bring specialists over some kind of remote connections, right?
We do that a lot. When we send nurses to the patient's home, even though they connect with the senior physician many times, and then we can consult with, actually we have on our back the whole Sheba team. So all the specialists of Sheba can help and consult on these cases. So definitely.
Definitely, that's great. Thank you. And I think we're ready for the next and final piece in the puzzle and the story here.
Good morning, Mr. Goodman. First of all, I would like to tell you that according to your urine culture, you have no infection, exactly as we saw in the outsend system. I see that your breathing has improved, your glucose levels are balanced, the area of the infection is smaller, and you don't have fever. Do you have any other pains?
No, I'm really feeling better. I don't have any pain, and I'm walking better, too.
That's very good. I would like to talk to you about something else. I understand from the conversation you had with Eleanor this morning that you're having trouble sleeping and that you're worried about late complications from COVID-19. It's very common to feel that way after prolonged hospitalization.
I'm not used to feeling this way.
I understand. And it's great that you're sharing your difficulties and your concerns. I would like to send you XR health glasses with the drone. You can read all about them on the tablet. There's a special program there for relaxation exercises. It can make things easier for you and help you sleep better.
Sounds good, thank you.
Breathe in. Breathe out. Breathe in.
Dad.
Yeah.
Hi. The doctor wants to speak with us. Here, okay. I'll take the glasses from you.
Oh, thanks.
Get ready to continue.
Hello, sorry.
Good afternoon, Mr. Goodman. So today we'll be discharging you from your home hospitalization. You've really improved. You can find your release forms in the tablet on the Dado system, and there's also a personalized video for your continuing care, including instructions on taking antibiotics orally for another few days. Now, some of the technologies like the Echo Care system and the Outsend system will remain in your house. And later today, a nurse will come over to take out that IV port and to give you more explanations in person.
Sounds great.
Thank you.
Dr. Eve, I really want to tell you this home hospitalization was a really great experience for me. I felt safe and in good hands.
That's great. I'm glad. So be well. Take care.
Okay, so we saw the happy ending of our patient at Sheba Beyond Hospital at Home, and one of the important technologies used here was the XR Health technology, which is the virtual reality solution, one that is actually FDA cleared for physiotherapy, stress reduction, ADHD, etc., both collecting information, analyzing it, and giving reports to clinicians. Dr. Levine, have you implemented any solutions for stress reduction in your home hospital systems?
You know, we've looked at the XR Health system. We have yet to implement anything in particular. But again, you know, we have quite a few touches in the home from our clinical team, and obviously they are always working on stress reduction pieces, but we have not yet implemented a specific AR or VR solution like that. And oftentimes, you know, things like music therapy, as well as looking into, during COVID, we're looking into starting a partnership with actually a harp therapist, potentially. But other than that, not any high-tech solutions quite yet.
Okay, great, thanks. And, you know, one of the key things we see here is that treating patients remotely is slightly a different type of medicine and requires training and high level of training for physicians to be ready for that. Dr. Barkai, can you tell us a little bit about the training and some solutions and simulations you use for that?
Yes, of course. When we started promoting telemedicine in Sheba, we understood that we have to train the clinicians to this new way of providing medicine. So we developed together with Messer, with the Israeli Medical Simulation Center, we developed a special course in which we exactly touch on these things, how to make an effective communication. We do it with actors and simulations, just like we do it here. And we let our clinicians try to have these conversations and see how they cope with training patients from afar, discussing with them, and it's really successful.
What have you been doing for training, Dr. Levine?
So we also are using our simulation center. We've put together less video-based teaching, which I agree very much is very necessary. Unfortunately, that is not a part of U.S. medical schools, is telemedicine training, and it really needs to become a bigger part. And there's some great work being done in that area now. But we do use simulation training to plan for kind of never events, challenging patient and family relationships for a lot of our training. And I think that's been very effective.
So, you know, David, this year I managed to enter a few courses of telemedicine into Tel Aviv University training for physicians. So we're going to start doing that as well.
And your physicians can join them remotely, I'm sure.
Sounds wonderful. We'd love to.
Great. And I think we're ready to kind of start summarizing. And Dr. Segal, you know, you've put robotics into extensive use in your hospital internal medicine ward. What is the potential to implement them in the hospital at home scenario?
Well, it depends, because the term robotics is applied for a large field of technologies, but it helped us a lot with the COVID-19 departments, and it has the potential to help us a lot at home. It opens a different discussion relating to the preparedness of the home to the technology. Mm-hmm. Because the robots have to go through the stairs or over the carpet. So once again, this is a huge field of technology that is still evolving, but certainly it's going to help us a lot in the future. I have no doubt about it.
I'm sure.
But what we used is not exactly robots. It's telepresence devices, which are actually a way to bring us to the patients and not a robot that's not personalized. So it's a bit different.
Absolutely. And Dr. Levine, you want to comment?
Just to build on that, you know, one of the projects in my lab right now is actually getting at this very tough question of, right, do you care for patients without that support at home? Mm-hmm. And if so, how? Because right now, in order to do that, we have to push in home health aides and, you know, physical people to provide that extra care. And so one of the projects in my lab with our collaborators in robotics is actually building robotic suits for patients. Don't laugh too much.
Wow.
But essentially robotic suits that keep people from falling, help people to get up from their sofa, things like that, in order that even when they're acutely ill, we can still care for them at home, but do so with less physical, assistance, so that somebody who initially is a one-person assist or a two-person assist could actually potentially function by themselves. And so I think it's early days, but it's really exciting work and is a nice collaboration between kind of the general internists in the home as well as the roboticists in their lab.
Yeah, we look forward to seeing that in our next demo here, Dr. Levine.
But then they will be completely lonely.
And to build on that, Dr. Levine, what's next for the home hospital in terms of technology? Give us your crystal ball look of what's coming up in 5 years.
Sure. So I think, one of those areas is building more sort of robotic assistance in the home, like I just mentioned. I think one of the other areas that we're working very hard on are really predictive algorithms to use the data that we either already have and aren't using appropriately, or to get new data, right? Maybe it's the audio from the home, maybe it's the OutSense defecation system, but systems that we haven't tapped yet, that for clinicians are often some of the most important things we look at, right? Someone's tone of voice or how someone's breathing when we just walk in the room. Those are some of the most important things we get, but we can't quite get those from machines quite yet. And so I think there's a lot of room to be done in the algorithms that we use for the sensors we have. And then I think finally, we're working a lot on new diagnostic pathways, right? And portabilizing the kinds of things that we need in order to care for even more complex patients. Whether that be suction, which seems simple, but it isn't always very simple, and other kind of more advanced systems, whether those be capsule systems, swallowables instead of wearables, things of that sort are places we're focusing on.
So that's great. And I think some of the technologies you mentioned, like the voice analytics and the excrement monitoring, we see the early signs of them here, and we'll obviously follow them very closely over the next few years as they become kind of used in mass implementations. And Dr. Barkai, Sheba Beyond is just being launched now. So where will it be in 5 years? Beyond the United Arab Emirates, where else are you going?
So I definitely see us really doing a change in how healthcare is being delivered worldwide. We're doing a change now. We're having a transition to new models of care that include, as I said before, our specialists or very highly specialized physicians. It's not instead of physicians and nurses and all other kinds of stuff, and leveraging them with the right technologies to be able to provide, care for everyone, everywhere, as you said in the beginning.
Great. So thank you very much. And I think we are at the end of our time. So this is I'll just to summarize. First of all, I want to thank this phenomenal panel. Thank you very much. Dr. Barkai, Dr. Segal, Dr. Levine from joining us from Boston. Thank you again. Sincere thanks to Messer for putting this whole setup here together. I think it's time to give us a wider look of what we have. What you see here is we've actually built this fake home that allows us to bring in new technologies and change it from an old person's home to a young person home, bring in different technologies, test them with actors, with simulators, and get real feedback and learning as we've seen here. So thank you very much for Messer, to the Messer team, ARC, Sheba Beyond, and digital transformation teams as well. Thank you for joining us, and feel free to reach out to us following this webinar through the contact information that's available on chat. We look forward to staying in touch and continuing this dialogue and continuing in developing and growing towards the 2030 vision that we are looking at. Thank you very much.